Good evening and welcome to Doc Talk Live at Matthews Art Center. Thank you for joining us tonight for our conversation on vein health. We're pleased to welcome Nick Czosnyka, a general surgeon from Spearfish Clinic, who will be sharing information about vein ablation, a minimally invasive treatment option for varicose veins and chronic venous insufficiency. So many people live with leg pain, swelling, or visible veins without realizing there's effective, minimally invasive treatment options available. So Dr. Nick will explain how vein ablation works, who may benefit, and what patients can expect. So please join me in welcoming Dr. Nick Czosnyka.
Thank you very much, and thanks for coming out to hear a little bit about vein health and treatments for varicose veins. So, the first thing I'll start by saying is, varicose veins are extremely common, right? And when we talk about varicose veins, this is a spectrum. You probably noticed when you were 25, you had a small spider vein on your leg that you didn't have when you were 10. And maybe as time has gone on, pregnancies, working, standing for long hours, people tend to develop larger varicose veins. And so you can talk about big varicose veins that you could see across the room. Maybe only 20% of people have something like that. And then if you talk about a small spider vein that seems to be getting bigger, or maybe your ankle's getting a little darker or something like that, that's a large percentage of people. Maybe somewhere 80% of people, 90% of people have some type of vein that's growing in size or prominence. And so the bottom line is it's extremely common. But when we talk about varicose veins, especially in the context of intervening and treating them, potentially with procedures, we need to really be questioning, well, what are we treating? The most important factor when it comes to assessing a patient's need for varicose vein treatments is their symptoms. Because if we don't have a symptom that we're making better, unfortunately, the desire to have them not be there isn't generally what is considered a good medical indication to intervene. And so the symptoms people often have, some are common sense. If the vein's bulging and hurts, if the vein is bleeding, that makes sense. But more commonly, people have things like swelling, aching, edema, or kind of their lower leg just gets a little bit bigger. There can be cramping at night. There can be restless leg at night. There can be discoloration of the skin, or even in worse cases, there can be wounds that don't heal, something we might call an ulcer. And so there's lots and lots of very common symptoms that people may be living with that they're chalking up to, I'm just tired, or I've just been on my feet all day. And so when we meet for the first time, the big question I'm asking is, well, what are we trying to make better? And so people might have a varicose vein, and this one varicose vein hurts, or is problematic. Maybe it's right next to your knee, or it's right on the back of your calf, and this one spot is what hurts. But like we kind of mentioned in the intro, varicose veins are just one part of a bigger kind of concept, and that's venous insufficiency. So if you think about how blood travels through your body, you've got your heart pumping, pushing blood through your arteries, getting blood out to all your tissues, and then your veins are the return pathway. And so your arteries are very dynamic, they're muscular, they stretch, and they're very strong. They don't get varicose veins. They don't, there are examples where arteries can become aneurysmal, but that's not what we're talking about here. Right? We're talking about low pressure blood returning out of your tissues. And the best analogy I can give somebody is think about this like a root system pulling water into a plant. If you were to take a plant and break away all the dirt, you'd be looking at thousands and thousands of little tiny roots. And that's how our tissues are with veins. You've got these tiny little venules that confluence or join together to make smaller veins, that confluence together to make bigger veins, that ultimately come back towards your heart. And so when blood is returning out of your limbs, let's say like your legs, it's got a long way to go. It's pumping up against gravity. So every time your heart pumps, blood is being pushed forward. And every time your heart's filling and resting between beats, there's a pause. And blood is not moving in those veins. So what happens is the blood is pumping up, and then it has a split second where it can be stagnant and it wants to fall with gravity back down. And our body has a really great system to prevent that. There's these check valves in your veins. Think of it kind of like a little one-way valve. Blood can pump through them, but then as gravity draws that blood back down, they close. And that way blood can kind of march up out of your leg in those kind of pulsatile motions to return blood to your heart. Well, as we age, as you've stood for hours at work, as you've had a pregnancy where a baby's sitting in your pelvis, kind of restricting blood flow out of your legs, causing higher venous pressure in your legs, those very thin-walled veins can stretch. And when they stretch, all of a sudden those valves don't work as well as they once worked. And so when you have an inefficiency of the blood getting out of your leg, there can be venous stasis, or a kind of a longer duration of time as blood is sitting in those veins, and that pressure builds in the veins to where then things stretch. And then it becomes kind of an unfortunate downward spiral. The vein is stretched, it's become less efficient at getting blood out of your leg, so then it becomes more stretched and more inefficient in allowing blood to get out of your leg. In time, as your veins stretch, that's how you develop those kind of more tortuous, bulging varicosities. But that kind of breaks down a little bit of the physiology of varicose veins. But what I was hoping to explain there is that is the concept of venous insufficiency. Poor venous outflow out of whatever limb we're talking about. In this case, generally the legs is the easiest to understand. So once you combine poor venous outflow, this venous insufficiency, now you start to get varicose veins, and that's where you start to get symptoms. So then the question is, well, how bad are your symptoms? What can we do to treat them? And the treatments start conservatively. We never, ever, ever, as surgeons, want to jump to surgery as an option, as a first line, because no matter how successful things can be, no matter how generally safe things are, the reality is the things we do can't be undone. That's just the nature of surgery. And so if we don't need to do it, that's a better choice, because there's no risk in not doing it. Even if there's small risks, there's no risk if we don't do anything. So the first line of treating venous insufficiency and varicose veins is just behavioral change. If you're doing something that hurts, can you not do that, right? And I'm not trying to be, flippant with that. But if your work requires you to stand, you got to be there. But if you're at home and you're, working a lot and your legs hurt, well, could you sit down and put your feet up for 10 minutes and take a break every few hours? Maybe that would give you a good relief. If that kind of behavior modification doesn't work, the next step would be compression therapy, things that augment the veins. The same idea of these veins being stretched and losing efficiency of those valves. Well, if you can put compression on your whole leg and kind of augment those veins to now maybe sit in a little bit more narrow configuration, now maybe those valves work better. And so if your symptoms are mild, this one little spot on the calf hurts, well, if you wear a compression stocking, if it feels better, that's a great endpoint. Maybe nothing more needs to be done. So there's lots of different compression stocking options. What I would tell you is generally the ones that people come to my office with are not as strong as the ones that would be recommended. There's a grading system, the millimeters of mercury of compression strength that we would recommend. And generally something you pick up on Amazon or you pick up at Walmart or Walgreens or something, or maybe you had from another surgery, like a TED hose or something, generally doesn't have that grade of compression. And so they're not bad to wear, and they might not be adequate. And so, a lot of times I'll see people after they've been dealing with this for years, they've been talking to their primary care doctor, maybe they've been put into compression hose or not, compression stockings. And if you haven't been, that would be the first thing I would say is if you're having symptoms, talk to your primary care doctor about getting some compression stockings that are graded at a maybe 20 to 30 millimeter mercury compression grading. And those can be had, at a local, medical supply store. We've got one here in Spearfish if needed. And the other concept is a lot of times people don't like wearing them, and I can fully understand why. Right? If it's the middle of summer, it's 100 degrees outside, they're not easy to wear, they're not comfortable to wear, but they generally do help when they're consistently worn. So if you've been given ones, and let's say they're knee high, and they're not working because maybe you've got veins up in your thigh, they make thigh high compression stockings. So that's what I would tell people is, start with compression stockings that address the area that bothers you. And if it's your whole leg, if you can tolerate it, wearing a full-length compression stocking while you're up and about. Not when you're home sleeping, not when you're up watching a movie on the couch and you can raise your leg and rest. But if you're at work standing all day and you're going to be out for, let's say, whatever your 8-hour day looks like, that's when you want to be wearing it. It's okay to take days off. It's okay to go to a wedding and wear a dress and not wear it that day. But in general, if you're going to commit to seeing, will this make it better, then I would recommend, a good solid period of time, minimum a month of trying to see if it gets better. As we'll talk about more, a lot of times when insurers go to look at their willingness to pay for intervention, one of the things they'll ask is, have you consistently worn compression stockings as a conservative intervention before they'll authorize, an invasive procedure like we'll get to talking about. So mild symptoms can be managed with behavioral changes. More moderate symptoms might be able to be managed with compression. But ultimately, if the symptoms are not manageable with conservative measures, that's the threshold that we need to meet to make a decision and have justification to intervene with a procedure, with a small surgery. And so the treatment options for varicose veins can kind of be thought of in 3 different procedures. The most minor would be something called sclerotherapy. And sclerotherapy is an injection of a chemical, a sclerosing agent that basically irritates the inside of the vein and causes it to scar closed. What is the problem we're trying to solve? Right? We're trying to solve poor outflow of blood and blood being kind of stagnant and not leaving the leg out of these troublesome veins. Well, if we close the vein with a chemical scarring, then blood can't travel through this pathway. And kind of back to my analogy of the thousands of little roots in a potted plant, if you close one troublesome pathway in your leg that's superficial, that's achy, that maybe bleeds, or whatever the symptoms are, there's a lot of other pathways, collateral pathways that blood will get out of your leg still. And that's an important concept to remember too, right? When we're going to intervene, we have to intervene in ways that address the trouble spots, but leave blood a pathway out of the leg. And this is one of the concepts that can be frustrating for patients, because in our legs, we have 2 very distinct kind of pathways that blood leaves our leg. One would be called your deep venous system, and one would be called your superficial venous system. And so the deep veins are veins that run below your muscles, close to your bone, ones that you can't feel, you can't see, but they're the bigger veins. They're the ones that the majority of blood exits your leg through. Whereas you look at the superficial veins, and these are the veins that ultimately link back to the varicose veins you see right underneath your skin. And the superficial pathway is the pathway we can intervene on. That's the one that we can kind of think of it generically as we can delete parts of that and still retain good outflow out of the leg through the deep system and whatever's left of the superficial system. But we can't take away both. There are examples out there of people trying to intervene in deep system reflux. I don't do any of those. That's not something that I would offer in Spearfish. And the concept that I kind of want patients to understand is if you come in with reflux seen in your superficial veins and your deep veins, we are not going to be able to get rid of all your reflux. There's just no way to stop. We need to leave some pathway for blood to get out of your leg. And so if that means leaving a refluxing deep system, then maybe the best case is, well, we're going to get rid of the bulging veins, we're going to get rid of the achy veins, we're going to get rid of a lot of the swelling and the edema, but maybe you're still going to have to wear compression stockings. Because again, what are we trying to improve? Symptoms. The easiest way to explain varicose vein kind of outcomes, what I would say is, if you look at the patient that everybody knows, like, not to be funny, but if you imagine the old lady that everybody knows around town that has varicose veins that you can see from across the room, that patient is going to have improvement. We can make a lot of those veins smaller. We can make a lot of those symptoms better. So symptoms are going to improve, and the appearance is going to change, and the appearance is going to improve. And when you have an extreme presentation, you don't have to do a lot to get an improvement. When you have a subtle presentation, now all of a sudden it's very different. If somebody comes in and they've got a few spider veins, they don't have a significant amount of reflux that we can demonstrate on an ultrasound, and we'll talk a little bit more about the workup of venous reflux. We can all kind of go in circles about trying to chase perfection. Improvement is the goal for these treatments. Symptom improvement is the thing I like to hammer home. Perfection is not the right endpoint to be seeking. Because even at the end of all of these treatments, if you come in with aching legs, swollen legs, big bulging varicose veins, and we get rid of the achiness, the swelling, the majority of the varicose veins, and there's still one spider vein behind your knee, that's a win. And it's very unlikely that if you're the type of person that has significant varicose veins, that we can ever get to a point where you never have varicose veins. That's just the inherent nature of aging and body types, and some people get varicose veins. And so success rates for varicose vein treatments are very high, and the quality, the lasting success is good, but it's not perfect. So we'll talk more about that once I get to the treatments, but we started with sclerotherapy. That closes small veins. And that's a same day office procedure under local anesthetic. We're numbing the skin. We're injecting this into a vein that we can either directly see or see under ultrasound to have it close. Very low risks to doing that, small risk of pain, very, very small risks of irritating the skin if some of that sclerosing agent were to leak out of the vein, but generally extremely well tolerated. The difficulty with sclerotherapy is it's so limited in what we can do with it. We can inject in small veins that we can see and directly watch the sclerosant go into it. This isn't for the whole length of your leg. Right? These are for trouble spots. So then if sclerotherapy isn't the end of what you need, then we can kind of jump up and look at, well, potentially phlebectomy or removing small portions of vein, directly cutting through the skin to pull out small segments of vein. Now, why would we want to do that? Well, if we don't think you need the more extensive treatment that I'll talk about next, and you still have these small varicose veins, we've kind of done some workup with ultrasound, and we see that the only place you have any reflux or varicose veins are right in this one spot. There's no indication to do a more extensive treatment. These are too big for sclerotherapy. Well, then maybe a small phlebectomy could be used to remove just that small troubled spot. But that's generally not how people present. People usually present where, okay, we've got veins throughout our whole leg, we've got symptoms, and why is that? Well, the concept I raised from the beginning, venous insufficiency. There is poor outflow of blood out of your leg. Well, where does that happen? It happens in the main trunks of that superficial system. Right? If you think about it again, like the root analogy, these are the larger roots that are getting closer to the trunk. And so in our legs, we have a greater saphenous vein that runs on the middle of our thigh, that runs kind of from your calf up to your groin. On the back of your calf, you have something called the small saphenous vein that runs on the back of your calf, kind of in the same. It is delivering blood out of the superficial tissues and into the deep system. And so there's an anterior accessory saphenous vein in your thigh that can sometimes be seen to have reflux. And so those are three very common kind of larger superficial veins that can be shown to be a source of reflux, that increased pressure distributes throughout all the veins in your leg, and that's why you see smaller veins enlarge. You see the varicose veins become more prominent. And so how we prove that is with an ultrasound. You could come in and say, hey, I've got this vein, you can see it right here, and I see it, you see it, we all know it's there, but is there a deeper cause to why that vein formed? And that's where an ultrasound looks at your legs during periods of kind of different positionings, augmenting on a table where the ultrasound tech who's doing the procedure can look and actually say, do I see the blood flowing the wrong way? Right? Do I see blood not marching towards the heart, but falling down with gravity? And if I do see that, over what duration, what length of vein do I see it? How big is that vein? That gives us information about how we can intervene. Because if your greater saphenous vein has a long segment of reflux and it's big enough to address, then maybe you meet criteria for vein ablation, which is kind of the most kind of invasive but still minimally invasive treatment we have for treating venous reflux. And so the goal here is to delete or remove the pathway for blood to get out of the leg. People often hear about, oh, my mom had vein stripping. My grandma had vein stripping. We don't do vein stripping anymore because it was a little bit more painful. It caused a little bit more bleeding, bruising, swelling. But really, if you look at what did it accomplish, it accomplishes the same thing we're going to accomplish with ablation. You're removing that pathway. But instead of having to literally pull the vein out to remove the pathway, which, is kind of painful and it's not an easy thing. Instead, ablation literally burns the vein closed from the inside. So kind of hold that thought. We'll talk about the procedure in a little bit. But by burning the vein closed, now there's not a pathway for blood to get out of your leg. So it has to find a different path. And so if you have a bunch of varicose veins that all join into that greater saphenous vein, and now we've burned it closed and combined maybe phlebectomy to remove portions of those smaller varicose veins that are superficial, that are visible, now those pathways are closed. They're not around anymore for blood to flow through. And so if they were aching because they were swollen, they're not there. So hopefully the aching goes away. If there's no pathway for blood to reflux in and cause a higher resting venous pressure, then hopefully you don't have new varicose veins form in any type of quick or, kind of frustrating way. And so ablation, phlebectomy, and sclerotherapy are the three interventions we can do to treat varicose veins. The question is, which ones would a patient meet criteria for? And that's where meeting a patient, physical exam, ultrasound are all used to understand what veins are causing a patient trouble, what's the underlying cause of those veins being present, is there venous reflux present, and if so, where in the veins, where in your leg is that present and to what extent? And then we'll apply those therapies. So you've got symptoms, you've tried conservative therapies, it hasn't worked in a way that's demonstrable. And so what I mean by that is, if you wear compression stockings once and you say, I just don't like wearing them. Well, unfortunately, some insurance providers don't like that answer. They want to say, well, before we commit to, agreeing to pay for a procedure, we need to see that somebody's done a diligent effort to try to have conservative success. And so I'm not an insurance expert by any means, but in general, the most stringent insurance would ask for someone to wear these for 3 months. Some insurers are much more laxed, others are very stringent. And so that's a concept that I think people need to hear. If you come in to talk about veins and kind of get a plan for how to address your veins, it is not a snap your fingers quick type of process. Unfortunately, it generally plays out in the weeks to month time frame, not the hours to day time frame. And so we talked about the 3 interventions. When you come to see me and you walk out, generally what I'm going to tell you is, if you haven't worn compression stockings, go home, wear compression stockings. Prescription will be provided if needed. In the meantime, we're going to get an ultrasound to evaluate your legs to see where exactly, if there is reflux and to what extent there is. And then with that information, we'll reconvene to talk about the ultrasound, talk about your symptom changes, whether it's an improvement or lack thereof, with conservative measures. And then if you're still having symptoms and there's ultrasound evidence of treatable reflux, then that's the threshold to then say, let's talk about intervening. And so kind of let me talk to you about radiofrequency ablation and what that looks like. So this is an office procedure. It's a same-day office procedure where you come in, you've already met me, you've met the nurses, you've gotten your ultrasound, and we've decided to do this. So then on the morning of, we generally ask you to kind of get up a little earlier, drink a little bit more water than usual, go for a walk to help your legs engorge a little bit with blood. Generally, we want your veins to be big. We want your veins to be as prominent as they can be. And just like we talked about relief from maybe resting and raising your legs, if you get out of bed and you've been sleeping for 8 hours and your veins are as small as they've been in a week, and then you rush into clinic and now your veins are much smaller than they were when we saw you for your ultrasound, it can just make the actual procedure a little bit more difficult. So we have you get up, walk around, drink water, help your veins engorge, and then we would see you in clinic. When you get there, there's an ultrasound tech who's scheduled to be there, a nurse in the room, myself, and generally a second nurse to help just run and get things if necessary. We would do what we'd call kind of a pre-scan, just to have the ultrasound tech re-look through the leg to make sure we're seeing the same information that was defined on the initial ultrasound. And if that looks consistent with what we expected, we would proceed with the procedure. And so generally, we start with ablation, where we cannulate or get access to the vein we're treating through a sequence of skin pokes. I guess that's the simplest way to describe it. All right, a needle would access the vein under ultrasound guidance. The ultrasound shows me where the vein is, and a needle can be watched entering the vein directly so we know it's in the right spot. And then a wire is placed into that needle to gain a pathway that's held into the vein. And then the needle can be removed, but that wire is still in place. And then a small, what's called a sheath, is inserted through the skin. It helps dilate or spread the tissues so then that there's a slightly larger tube accessing the vein. And then through that sheath, a treatment catheter can be put in. So this wire, at the end of it, is a small segment that actually heats up. And there's different lengths of that segment, but generally, let's say a 7-centimeter segment is the typical one that I use. And then that can be placed up, let's say this greater saphenous vein, under ultrasound guidance. We're watching, I'm pushing this treatment catheter up the vein until it's sitting right at the highest extent of that greater saphenous vein. And again, all this is being watched under ultrasound. And when that catheter is in place, then we're almost ready to treat the vein, but then what happens next is we need to kind of protect the tissues around the vein. It's literally heating up to a point where it's denaturing the tissue. It's causing them to be burned in a way where they shrink. And so we don't want all the other tissue around your vein to have that same heat transfer. So there's a solution, it's called tumescent anesthesia. The details of it are not really important. What is important is to understand what its purpose is, and that's to put a fluid around the vein that bathes the vein in a cool fluid that also doesn't allow heat to quickly transfer to the surrounding tissues. You kind of think of it like a heat sink, right? If you put a heat sink on a whatever, fill in the blank, a computer chip or something, it dissipates the heat very rapidly and doesn't allow it to accumulate. And so the same thing, the tissue that's touching this catheter heats up, the tissue that's around it, think of it like that, the water around it, so to speak, is not heating up nearly as quickly. So then the fat and the nerves and the skin that are around the vein don't get injured. And so we walk that heated catheter down the leg in 7-centimeter segments to close the vein. And then once that's done, then if there's other large varicose veins, think of it kind of like the ropey ones that you can see and feel, then we apply phlebectomy to those. Small incisions are made over those after local anesthetic is injected. The small portions of the vein are pulled up. And again, the concept is breaking up the continuity of the vessels. We cannot possibly remove every centimeter of vein from your leg. But what we can do is if there's a prominent pathway, we can remove it, and now blood can't flow through it. And so think of it like that. You're removing segments, try to get as much of that segment as we can, but the goal is to break up the pathway of blood flow, not to remove every centimeter of vein. That kind of makes sense, hopefully. Then once we've done the ablation, we've done the phlebectomies, we close up any small incisions with, you can do this a lot of different ways. The way I do it is with Dermabond, or basically skin super glue. So holding the edges together while it dries. Small Band-Aids are placed over that, and then your leg is wrapped in a combination of a couple different types of compression wrap. There's a Curlex wrap that I use, and then an ACE wrap. There's a lot of different ways to do this. You could put on a compression stocking. I like to use the ACE wrap because I think it's easier for patients in the immediate period after they have this procedure. But it's the type of thing where you can have it done the same day, you can go home the same day, you're awake during the procedure. So it is well tolerated, but I like to be very honest with people. I'm not going to lie to you and say you're not going to feel like you're having something done, right? If you've been to a dentist, you feel like you're having something done, and it's much the same. We can numb up what we're working on, but I can't take away the sounds. I can't take away the pressure and the pulling and the pushing. And so people are usually very comfortable, but it's not the type of thing that you could say, you didn't think anything was happening. There's a reality to you're having something done. 99% of the time, I do these in my office. In very rare cases, if somebody has a history of maybe extreme anxiety of procedures, or they've got such extensive veins that it's just going to take a really long time, then in rare cases we'll do them in the operating room. But in general, I try not to, because it's tolerated well, and that alleviates a huge cost. Right? If we go to the operating room, it's just going to cost a lot more to utilize those facilities. And so it's not something we generally need to do, but definitely it's important to hear that there's options, right? The majority of people can do this without it, but if it's the difference between doing it and not doing it, and you wanted to go to the operating room, it's certainly an available option, but it's not what is done most of the time. In the follow-up, in the recovery period, it's, I would say any procedure that you have done, whether it's a vein or a hernia or a gallbladder, there's kind of two ways to think about recovery. There's the immediate recovery, and then there's the more prolonged recovery. The immediate recovery is measured in days. The pain, the achiness, the managing bandages, having to not shower, right, for 24 to 48 hours. Those are things that are measured in days. And the pain afterwards is usually well controlled with Tylenol, ibuprofen, elevating your leg, resting, but not to a point where you don't do anything. We actually want you to be up moving around. In general, you can go back to work right away. If your work is very much where you're standing in one place on a concrete floor in a factory or something, well, maybe take a week off just to let yourself rest and have that time. But if your job is more kind of on the desk work side of things and you have the ability to sit and stand and move around and take a break if you need it, put your leg up, you probably could go back to work the next day as long as you keep your compression on and you kind of have those abilities to elevate your leg. So it is a well-tolerated procedure in the immediate kind of healing window. Now, what does it look like? Well, it looks like your leg bruises. There's not a lot of ways to make this sound like it's going to, be an immediate snap your fingers and everything's better. When we take veins out, when we make incisions, things bruise. And so that bruising, that healing, isn't going to be gone in 2 days. Realistically, that's going to be more in that 4 to 6 week period before you really can look at your leg and say, all I see are some young, fresh, small stab scars. In those first few weeks, you might have some bruising, you might have some swelling, you might have even maybe like cord-like feelings in those veins that have closed off and been treated. And that's normal. We are causing the veins to close by injuring them. That's the root kind of explanation. And so in those veins healing to a point of being healed and scarred to their like plateau where they're going to be forever, that takes a long time. It takes weeks. In that time, you generally are not feeling particularly off or uncomfortable, but again, your leg might be bruised. You might feel that cord in your leg where the treatment took place, and it's going to take a while for it to soften. But the reality is, it works. The success rates are very high. In the high 90s success rate, when you look at, are we making your reflux symptoms better? Are we making the painful symptomatic varicose veins go away? Yes. So if you look at a few months after this procedure, very high 90s% are going to say, I've had a marked improvement. Now, if you look 15 years out, are there people that get new varicose veins? Are there people that get recannulation or, veins that were treated maybe open up? Yes, but those numbers are very small. It may, we're not talking about, percentages outside of the single digit percentage. It's somewhere in the 1 to 9% type range, but it's possible. I guess talking to, in a generic term, if you're a person that makes varicose veins, if you're a person that has venous reflux, and that combination of a lifestyle that precipitates them and a body that is prone to them, if you get them now and we treat you, you're going to have improvement. But if you live another 40 years, you're probably going to get another varicose vein. Right? And that's not to be discouraging, but I think it's important to have realistic expectations. Again, if we're coming at this from a point of view of, are we making things feel better? Are we making the symptoms better? The answer is almost certainly going to be yes. Are we going to make things look perfect to a point where you say, I look like I've never had a varicose vein, I'm never going to get one again? That's probably not a realistic endpoint to expect. So I think I've kind of covered, physiology, symptoms, interventions to manage those symptoms, and ultimately the endpoint of intervening with ablation, phlebectomy, and sclerotherapy. I talked a little bit about the recovery. Are there any questions anybody has? All right.
So you say that varicose veins are common.
Yep.
So what are we doing as human beings that these valves are not holding up for a lifetime? And is this new? Is this in the last 50 years we've noticed it? Is it getting worse?
Yeah. So I'd say the concept, I don't think there's not going to be a black and white answer here, but the concepts that I think are true are sedentary life, blood outflow out of our bodies works really well when we move. right? Our muscles actually help push blood out of, our contracting muscles help blood leave our extremities. And so if you don't move, blood doesn't move. At least it doesn't move as well as it could. So you combine sedentary life with weight gain. Weight gain changes our tissues. It changes the amount of tissue that needs blood to be delivered to it. It changes the shape of our tissues. And so it's not a black and white, it's just weight gain, it's just sedentary lifestyle. But I would say if you look at our culture, our society as a whole, those are probably the two biggest issues, right? And then you combine with the, jobs that don't require us to move. Right? If everybody's job was to hike 10 miles a day, I don't think we'd have a lot of these problems, but that's just not the life we live. So, yep.
So you said that for compression socks, to wear them effectively, you can wear them at your knee, which I have on some right now, or you can have them up to the thigh.
Mm-hmm.
Do they make them like in a tights form?
Oh,
Because I don't know about everyone else, but us big girls, if you wear them up here where you need them, they gonna roll down, okay?
yeah.
I need like one of those hooker, things
Yeah.
where you can attach it. I don't know.
Yep. So they do, and it's the most common complaint from patients. They're very hard to keep on. The things that I've heard people have success with are kind of getting ones that have some type of kind of tacky
Hooker strap.
Yeah, like a tacky upper portion, and then also getting them kind of pre-stretched out so you can actually get them on and have them be tolerable. So something that you could get is like a big 3-liter pop bottle and roll it down on top of the pop bottle, let it sit on that overnight when you buy a new one.
Other questions?
This is a little redundant, I think, but the first step is to go to your general practitioner.
So not necessarily. So I brought the general practitioner up just because they're the ones the patients almost universally see first. If you've been discussing this with your general practitioner and you're seeing them soon, the things you can ask about are, can I get compression stockings? Can I get a referral to see Dr. Nick or a vein specialist? But the bottom line is you don't need that referral. If you want to see myself or Kayla Hatton, the nurse practitioner I work with, that oftentimes sees vein consults kind of as the initial consultation, you can just come to see us. And in general, a general practitioner is very, very good at kind of getting a sense of, is that going to be a fruitful visit? Because I don't want you to come and be frustrated when I tell you, well, I don't see anything. I'm ordering you an ultrasound. Oh, and by the way, the ultrasound didn't show anything. I'm happy to do that workup for you, but sometimes if a general practitioner knows you well, things are just a little bit more easily understood. Is this an appropriate referral? We can see you. I'm happy to see patients without a referral. If you know you've got big varicose veins and you're like, I just don't have a primary care doc and I want to see you about just veins, please come and see me. And your primary care doc probably knows you well, and so they would be a good kind of first step. By all means, if you want to be seen in the vein clinic, please come and see us. So compression stockings to try and assess whether or not conservative management will work. Ultrasound is going to be necessary to assess kind of the anatomy and the objective measures of what venous reflux is and whether it's present. And then only if conservative measures fail and there's evidence of reflux that we can intervene on successfully, would you meet criteria for ablation, which is a very successful, very tolerable procedure that will almost certainly give you improvement with very low risk. There are small risks. I didn't quite mention these earlier. So very small risks of things like, bleeding at the stab sites, having inflammation and pain along the treatment site, small risk of discoloration of the skin, but that's one of the other reasons that tumescent, that kind of buffer solution, gets put in there to help push the skin away from the vein being treated so it doesn't have any exposure to the heat. And in the very, very rarest of cases, there's risks of causing blood clots. And how we avoid that is, again, doing the procedure under ultrasound to avoid treating too close to other veins that could precipitate injuring those veins and causing blood clots, and then also following up the procedure 2 days after the procedure with a ultrasound to prove that that hasn't happened. If a blood clot were to form, it almost always forms in an incomplete way, not one that's causing complete obstruction of the venous outflow in your deep veins, but one that might just be a little bit protruding into the pathway of that deep vein from its connection to the vein we treated. And if that's the case, potentially treating it with, in some mild cases, aspirin for a few weeks, or in some more severe cases, a true anticoagulation for a month or two. But those are rare complications, and so I wouldn't get too worried about those. But they're something that I would discuss with you in a complete discussion.
Thank you so much. That
You're
was
very
very,
welcome.
very informative, and it's nice to know we can go directly to you.
Thank
you
you.
all for joining us.